Dr. Johann Samantha. He is a movement disorder specialist and neurologist who practices in Arizona, specifically in Phoenix and in Tucson as well. And I was sharing that you do a great amount of work with Parkinson's, dystonia, and that you have some good insight to share about dystonia as well as drooling and some ways that we can deal with some of these, you know, that are problematic in Parkinson's. So I'm going to turn it over to you, Dr. Samantha. People will write questions as they have them, and then we'll ask you after you talk for a little bit. So okay. How about that?
All right, that sounds great. Whatever works for the group, really. So thank you very much for tuning in. As Sarah said, I'm Johann Samantha, and I'm a movement disorders neurologist here in Phoenix. And Sarah we were talking about what could we, maybe a little topic to discuss. And so both in treating Parkinson's disease or folks with Parkinson's, as well as when I treat folks with dystonia who don't have Parkinson's, oftentimes there is a role for Botox or botulinum toxin, and and there are actually a few different manufacturers of that. But one of the big areas
Dr. Samantha, your volume went out. It's so strange. It just cut out.
Yep.
Oh, here you are.
All right, it's back. Okay.
Yeah. Oh no, it went out again. We might have to have you call in on the phone. Let's see. It's strange. It just knocks out.
All right.
Oh,
now it's working again, right?
Yeah, it's got a gremlin.
Yeah, I don't know why it does that. I apologize, folks. But so this whole dystonia thing is, it's really just a symptom. So when I treat folks with dystonia who don't have Parkinson's, it's usually an inherited or familial kind of thing, a little like essential tremor. But dystonia can sometimes be a symptom in Parkinson's as well. So
it went out again. I'm wondering if we should have you call in for your volume.
All right, let's see. What's the number again?
Let's try that. Okay, so if you dial 1-408 638 0968, and then I'll give you the meeting ID once it asks you to put it in. Okay, the meeting ID is 276 918 494. See, we can do sign language. Let's see if that works better. There's always something when it comes to technology.
All right, how's that?
That's perfect. Okay.
Right, there we go. Let's see. I'm gonna turn down the volume on the computer. There we go. All right. So all right. So as I was saying, so dystonia is really just involuntary muscle contraction. So people with Parkinson's can have that. A little different than just rigidity. So
One of the common ones is foot cramping or foot turning when you're walking or your meds wear off. Another one is what we call blepharospasm, so eyes closing and not wanting to open up again. But we also have folks who may have more, more complicated things like cervical dystonia, so the neck wants to pull, and that could be part of dyskinesia when there's overstimulation, overexcitement of movement, with medication sometimes. And then there is something pretty unique for Parkinson's patients. I don't really run into it much in our dystonia patients, but that is the problem of too much saliva, drooling, which can really be frustrating for our people with Parkinson's. And as it turns out, not only does botulinum toxin work very well to relax muscles, it also works really well to kind of dial down or turn off mucous membrane. So salivary glands, sweat glands, mucus cells, that sort of thing. So we can inject the parotid gland here or the salivary gland down here under the jaw and basically dial down the amount of saliva that's being produced for up to 3 or 4 months. Then the problem there, or the thing that we always have to balance, all right, there we go. So it said I was muted for a second. I don't know why. So the thing there is, of course, we don't want you to go around with a complete cotton mouth or completely dry mouth. And the key there is, so we know that between the parotid glands and the salivary glands, the parotid glands are responsible for about 30 to 35% of the saliva you make. And they're a little more on demand. So, around mealtime, or you smell a really delicious, you smell pizza, and you're, oh, I want that, and the salivary glands kick in and start to work even before the pizza's at the table, which is great when everything's working well, but not so great when you're already having trouble with drooling. So oftentimes we'll try to inject those first. That way we don't worry about overdoing it. But from time to time, that's just not quite enough, and we'll inject what are called the submandibular glands, that are right under here. And for a lot of us, we can kind of almost feel them, and you can milk them a little bit. You feel them just a little bit in front of the corner of the jaw down here, and if you squeeze or just kind of massage them, you'll notice that your mouth gets wet, and it kind of feels a little funny, like with hard candy or something. And so we can add that, and that will sort of boost the effect. And it's really probably one of our most effective and kind of cleanest, if you don't mind the air quotes, treatments for excess saliva, because there really aren't any systemic side effects. So if we inject your salivary glands, it's not going to make your legs weak, or it's not going to make you sleepy or nauseous or anything like that. We do have to be careful about, especially when we're injecting here, because there are definitely muscles involved in chewing and swallowing around here, and we don't want to make those weak or affect that. If that doesn't work, or some patients just would rather not see a needle, we'll sometimes use the atropine, the drops. So those are the drops that your eye doctor puts in your eye to dilate your pupil. And they are what is called an anticholinergic. So they block acetylcholine in mucous membranes very well. So a drop or two under the tongue will help dry the mouth out for 4 to 6 hours. again, even though it's a very small dose, we want to make sure that people don't accidentally squirt a whole dropper full in their mouth and are swallowing it, because we know from other medications that work this way that anticholinergics can make you kind of groggy and confused if you're ingesting them. So the key with that one is that you just want a drop or two into the tongue. And I usually recommend folks actually spit back out after about 30 seconds. You're going to get enough absorbed that way without ingesting very much. But when it comes to botulinum toxins or Botox, being the kind of the brand that everybody recognizes, you know, we really have. It's really quite versatile for those of us treating neurological motor disorders, movement disorders. Really anywhere where we see overactive muscle contraction, there's potential to consider using that for relief. So like I said, in a disorder called blepharospasm, which some people with Parkinson's may have as well, the eye muscles, the eyelid muscles are overactive and they squeeze and want to close, or in some cases, particularly with some kinds of Parkinson's, it's not so much the squeezing, it's the release and open your eyes once they do close. We call that eyelid opening apraxia. I feel like I need a whiteboard behind me to write these down, but maybe next time. And so what we do there, the goal there is we actually inject right on the eyelid muscle on either corner here and then around the eye. And what the toxin does is it basically causes those muscles to relax and stay more relaxed for about 3 months. And so that squeezing isn't as strong. Again, if you put too much in there, well, then you won't be able to close your eyes all the way at night, and you'll have a red eye and those things. So it's important that you have experience using it and you understand the dosing, and that that whoever you go see does this a fair amount so that they're comfortable with what they're doing. But I know over the years, certainly I see a number of folks with cervical dystonia, torticollis, so pulling of the neck, and over the years I've had a number of Parkinson's patients who have had that issue as part of their Parkinson's, and where we've been able to improve their range of motion, their posture, and their comfort level quite a bit by injecting those really tight muscles and getting them to loosen up. And that's really, as I said, that's the beauty of botulinum toxin or Botox is it's a very, very specific muscle relaxer. So normally if you think of a typical muscle relaxer, you take a pill and it's just hitting everything, and you hope that the muscles that are tight relax enough at a dose that doesn't cause your legs to feel rubbery or you to feel sleepy, and which can work for things like a pulled back muscle or something like that, but is often not as successful for something like dyskinesias or dystonia and the like. So when we're talking about something focal with a lot of muscle contraction, the nice thing with Botox is you inject the muscle that you want to inject, and really you're not going to have to worry about, well, I've injected the right arm, I don't need to worry then about legs feeling rubbery or tired. It doesn't go through your system, so you don't need to worry about what's it going to do with my liver or my kidney, or how's that going to interact with my cholesterol medication or my thyroid medication? The answer is it doesn't. It doesn't get out into your system enough to any real degree to be an issue. So that's another really nice thing about it. And these days, is that's about probably close to half of what I do or in my office is it's about 50% Parkinson's follow-ups and 50% various kinds of injections for dystonia and the like. And of course, I think a lot of folks may have already heard about treating migraine with it. Not a movement disorder, but it's something, the use was basically discovered in treating people with blepharospasm and facial spasm who would come back and say, well, boy, not only is the muscle twitching better, but I haven't had a headache in 3 months. And so from there, that's where the study started on that. Not to mention, that's also sort of where all that the dermatologists and plastic surgeons started using it, because we noticed that when we were injecting people with facial spasm, their wrinkles went away, or they looked a lot flatter. And so suddenly there's this whole cosmetic side of things. But the real purpose of Botox was treating neurological disorders like dystonia, like drooling, like spasticity. So if people who've had a stroke and their muscles are tight and spasmed, we can inject those muscles to help loosen them and give them range of motion back, and helps their therapy as well.
Dr. Samantha, I don't know if you can hear me. Can you hear me?
Yes.
Okay, great. Hey, we have a question for you. Can this treatment be used for rigidity around the waist to loosen the trunk area?
Right. Okay. So, and I guess everybody can hear that, so I don't necessarily have to repeat it. But yeah. So I assuming we're talking about Parkinson's now.
Correct.
In theory, there are situations where I've used it for something like that. But in the trade-off is for something more general like that, where both sides maybe are very rigid, we want to be careful, because by relaxing the muscle, we're also going to functionally make you feel a bit weaker there. But there are probably some circumstances. So I've had folks who have a lot of rigidity in their hip flexors, and they're kind of jackknife bent at the hips or at the waist, where we were actually able to help them achieve a better posture and more upright stance by injecting those hip flexors. And it did take some trial and error to make sure that we got enough relaxation in those muscles without causing them difficulty, lifting their leg up into bed, or, we're trying to get in and out of a car or something like that. So it's always important. We have to consider which muscle's causing a problem, but then what does that muscle need to do in our day-to-day function? And so, I can certainly see where someone might have a lot of rigidity that pulls them to one side, where we might, under the right circumstances, if that doesn't seem to respond to levodopa or the other Parkinson's meds, where it might make some sense to try around, or a series of injections.
Okay. Are there any consequences that we know of to the long-term use of Botox or another, one of those medications, MyoBlock or another one?
Right. I guess, to be fair, I should say, so there's 4 brands of botulinum toxin. Botox is kind of like the Kleenex or Xerox of, that's one that's been around the longest, and we kind of tend to swap and use that and botulinum toxin interchangeably. But there are 2 other type A botulinum toxins. One's called Xeomin, and the other one's called Dysport, and they've been around in Europe and in Asia for decades, and about 5 to 10 years ago became available in the US. They're all slightly different from each other in the processing and whatnot, and they're all about equally effective. And really it's a matter of having options in case maybe someone doesn't respond quite as well to one or the other. And then there's a fourth kind that's actually a slightly different strain of toxin called type B toxin, and that's called Myoblock, and that's been around for about 13 or 14 years now. And so now tell me, or gosh, all right, remind me the actual question. Now we went on a.
Sure, no, that's actually really helpful. Do we know of any long-term consequences for it?
Sure. So long term, and we've now been injecting people with botulinum toxins since about 1979, and so we have coming up on almost 40 years now. 30 some years of patient experience with it. Literally millions of patients when you add in the cosmetic side. And there's been no evidence, even in patients who've been treated for decades, of any increased, medical disorders, liver, kidney, immune disorders, cancer, anything like that. It seems to be very, very, again, clean is the word I come back to, for lack of a better one. It's actually one of the most, it is the most studied drug in medical literature. So there have been more papers published on it than on any other topic in the history of medicine at this point. So it's pretty well vetted, if you will.
Great. We have another question. Do you need another injection every 3 to 4 months for the span of the disease?
Right. So about treatment duration. So it depends a little bit on what you're treating and what and what your response is. For something like dystonia, which is chronic, and tends to be a lifelong disorder, most folks are going to be seeing their neurologist and getting treated every 3 to 4 months, so 3 to 4 times a year, for their lifespan or for the duration. Now, there are folks, maybe 10 or 15% of folks who may go through a remission when it comes to dystonia. And then when it comes to Parkinson's patients, well, your Parkinson's symptoms can ebb and flow and shift and change over time. So I certainly have folks that, boy, I've seen them, and I see them every 3 or 4 months ever since I was a fellow. So, a frighteningly long time as it's becoming. And then I have folks that, particularly among my Parkinson's patients, where, boy, we really needed to do this and treat something like maybe it was their neck and their shoulder was spasming and pulling. And we treated it, maybe we treated it for a year, 3, 4 injections or 6 injections. And gradually we noticed that it wasn't coming back, or because of other changes in their treatment and their Parkinson's, that just wasn't a prominent symptom anymore. And in those cases, then we don't. And the way I look at it is, it's, hopefully something nicer comes along as a treatment down the road, but it's darn good that we have it, and that we have great evidence that we can use it as long as we need to in anyone.
Are there any side effects from it?
So side effect wise, the primary side effect is really the effect. So what Botox does is it kind of, depending on the dosing, blocks some or a lot of the signal from the nerve ending to the muscle. And by doing that, that's where the action is, or sometimes not the muscle, but the salivary gland or what have you. But so there's always such a thing as an overly relaxed muscle. So if we put enough of a dose into a muscle, we can make it really not want to do much of anything for the chunk of those 3 months. So weakness is one. It's always temporary, so there is no permanent block or damage to the muscle or those sorts of things. And so given usually just the peak period of the injection, so maybe that first month or so, if you're going to have some weakness, that would be when you would have it, and it would gradually go away. And then the next time around, we might change the dose, or we almost certainly would change the dose to that particular muscle or group of muscles. And then coming back to especially injecting the neck muscles, and a little bit of what I'd commented about the injecting here under the jaw is when we're injecting in those areas, there is, we have to be cognizant of, what's in the neighborhood. And that's your swallowing muscles and your esophagus. And difficulty or awkwardness with swallowing can occur temporarily after injection. It's usually pretty mild, and it's usually not because of weakness. It's actually because of those mucus cells are also can be affected or take up some of the toxin. And if you've ever had a really dry throat and tried to swallow something like, a bite of a sandwich and felt it stick, well, that's what people complain about or will tell you about. And again, always temporary, and usually very mild and really pretty infrequent, even when we're injecting here. And there's no reason anyone who's being injected around the eyes or the back of the neck or in the arm or leg should have any swallowing difficulties. It's really a very local issue if it does occur. And that's really it. Now, there are some things that are ubiquitous to getting an injection, so bruising, that's a little local irritation. That's usually pretty transient. There really hasn't been a known case in all these years of an allergic reaction or anything like that. There's been a question about whether, can it affect your pulmonary function? And at least, while there have been some cases that have been brought up over the years, the best answer I have is that there's never been a case of a major respiratory or breathing issue in a patient, in a walking, talking adult patient, given an appropriate dose. So we think it's very unlikely. There may be some very special cases, again, where we might want to be extra careful in the dosing, but that for I think the majority of the folks that would be involved with this, there really shouldn't be any concerns about that either.
Great. There's a question, does DBS help with dystonia?
Yeah, so there definitely is. So we think of Parkinson's and tremor a lot when we talk about deep brain stimulation and DBS, but DBS has been used now for a good 20 years in treating dystonia symptoms, and not just dystonia symptoms related to Parkinson's, but in primary dystonia. Some of the most dramatic outcomes have been in children with primary familial dystonia, the generalized form. So these are the kids that really, are almost, they look like they're almost folded over and they're twisted and their whole body's involved. And I've seen some really remarkable outcomes there where, within months, they're running and skipping and it's, you really struggle to even tell that they had dystonia. Now that's not what everybody should, is not going to be able to expect or have those kinds of results, but we've seen over the years, as we've gained more experience, that people with adult onset symptoms, so torticollis or blepharospasm, other dystonic symptoms, also respond. They may not always respond as maybe as dramatically or overwhelmingly as some of those young onset children do, but on average, we're talking about 60 to 80% improvement, which is certainly nothing to sneeze at. I think the key is that we know why the person has dystonia to begin with. And some of the secondary forms of dystonia don't always respond as well. So cerebral palsy with dystonia isn't always as responsive. There are other forms of degenerative or inherited disorders that may have some dystonia as a part of them, and that can be a little more hit or miss. But in general, yeah, we certainly do use it there.
Okay. There's a question about, is Botox recommended for full body rigidity for someone who's no longer mobile, or are there ways, is there something that can help with full body rigidity that results in mobility?
Right. So unfortunately, there is a total dose limit to botulinum toxins, and it's, there's a little variation in terms of, how high you might want to go, but there certainly is a limit from one practitioner to another. And with more total body rigidity or dystonia, the issue has always been that we probably can't give enough to really treat all those muscles without starting to worry about having more general effects. And that's so the first part of that answer is probably botulinum toxin is not the right, it's not necessarily the right answer there. And that the whole setting of, that I'm assuming, again, this is probably someone with Parkinson's and whole body rigidity. It depends a little bit on maybe why or how we've gotten to that state. So if there's been no response to dopamine, levodopa, those medications, well, then we're probably talking about a Parkinson's plus syndrome, maybe progressive supranuclear palsy, or one of these other Parkinsonisms. And that's probably the most difficult group to try to get some relief for. We might use medications like baclofen that we use in people who've had strokes or spinal cord injuries, or Xanaflex, which is another central anti-spasticity drug, to try to relieve them if L-Dopa and dopamine drugs have not worked. If they work, but maybe they aren't able to tolerate the medication, depending on, and that's the reason that things have sort of gotten to this point, well, then there may be, and I have to emphasize may, because I just don't know, it would depend on each case, but there may be a possibility that they might still be eligible for deep brain stimulation, in which case, if they have had a history of responding to dopamine, that would bode well for them getting at least some degree of relief from that rigidity.
Okay, great. Another question is, do you develop resistance to Botox treatment?
So in general, you don't. It doesn't, we do recognize that there's a very small percentage of patients that may lose response. And that, so starting in, I believe, 1997, it was sort of reformulated. Essentially, the filtering and purification process, the technology had improved from the 80s enough that they really got a whole new process patented, and it has it's a more pure form of botulinum toxin. And in people who began treatment after 1997, the rate of resistance or loss of response is under 1%. It used to be closer to 10%. And so clearly we think the process, it may not even be the toxin that people become resistant to or develop antibodies to, but maybe some of the other proteins that are tied around or associated with the toxin as part of the complex that is botulinum toxin.
Okay. Okay. So does it work though for what percentage of people does it work for?
Well, so it will have an effect on pretty close to 100% of folks, and the real issue then is just, can you find the right balance or dose that gives you a good response, treats the symptoms that you're trying to treat, and doesn't cause either too much weakness or dry mouth or something like that. But statistically, about 70 to 75% of folks will see a marked improvement right from with their first treatment and continue to do well. And then if you take, say, that other 30, the 30 folks that didn't respond, and bring them back in 3 months later, make adjustments in the dosing and whatnot, then usually 2/3 of those folks are going to come back after the second injection and say, yes, wow, this actually does work, and they're going to do well. And then if you can convince that last group of 10 that's got 2 strikes already to try it one more time, make some more adjustments, half of them, roughly, are going to come back and do well. So with 3 trials, 95% of folks, 94 to 95% of folks will respond with a significant benefit, an improvement in their symptoms, and will continue to do so long term.
Well, that's really encouraging, but I think it's also really good for people to know, so many of these medications for Parkinson's they're quick acting or relatively quick acting. And so we're used to a quick response with things. And even though it's a long-term disease, so we've got a little bit of time to actually see if it's going to work. It's kind of nice to know that you want to try to go through maybe 3 cycles, which is then like 9 months, to see if you can tweak it properly. Right.
And thankfully, usually we at least have gotten some relief with those first couple of treatments. And speaking of that sort of the immediate versus maybe a little more delayed, it's important to maybe emphasize too that the Botox, the injection doesn't start working or you don't see results sort of when you get off the table or as soon as it takes about 24 to 36 hours for the toxin to actually get taken up into the nerve ending. And on average, it's about four to 7 days before most patients say, I started to notice a change in my symptoms. And in terms of the way that the toxin works biologically, it takes about 14 days to reach its peak full effect. And then it sort of levels off from there. And it takes your body, the neuron, about 75 days to undo what the toxin did. And that's where we get kind of roughly that 3-month kind of window there. So. Okay.
Well, it's really nice to be able to hear some options for treatments, that there's no cure for Parkinson's, there's no cure for the dystonia, and the drooling, and really good to hear about just even the eyes, the closing of the eyes and the issues with that. I mean, it's just nice to know that there's options out there. And I just want to reiterate, before you came on, we showed on our website how you can actually find movement disorder doctors. And when he talked about finding someone who has a good amount of experience with Botox, I think that to me, that just sort of emphasizes the importance of finding, the movement disorder doctors, like you do a lot, you do these clinics regularly. So you have expertise in it. And I think that's really important. And we want to help drive people to people who have expertise in these areas.
Yeah, these are not, these aren't simple treatments anymore, and they're definitely, you know, repetition builds competence, as they say. And I think if I'm not saying that we're necessarily any smarter or anything like that, but boy, you know, there's something to be said for experience, and when it comes to Parkinson's and dystonia, that's, I think, you know, you'd like to see the most experienced people in, you know, that deal with the issue that you have. That's not always, you know, feasible on a regular basis, but I think it's valuable, at least, you know, to have seen someone, you know, at least once for an evaluation, and maybe have them as a, you know, as a backup person, or the person you can go to when you and your local neurologist or your local doctor aren't sure what to do next.
Right.
So
Right.
that's a resource.
Right. It's a complex disease, and it's different for everybody. So I'm aware of the time, and I want to be able to get you back to your clinic, but we are so grateful for your time and sharing your expertise with us. This has been tremendously helpful. Thank you for that.
Thank you very much for having me.
And we will be putting this up on our YouTube channel, and we'll put Dr. Samantha's contact information on there as well, so that you know how to reach Dr. Samantha. But we are so grateful for your time, and just that you share your expertise with us.
You're very welcome. Thanks. Thank you, everybody, for calling in.
Thanks for joining, and hopefully we'll see you all next month on the 4th Wednesday. Thanks a lot, and have a great day. Bye-bye.